intercondylar depression between ACL, where ACL inserted, and the entire tibial spine with medial and lateral plateau, but it's less frequent. The patient presentation is divided into acute setting and chronic setting. In acute setting, the patient will present with pain, limit range of motion, knee swelling, and inability to bear weight. In the chronic case, they must present with the joint instability, the recurrent effusion, and the restriction in passive and active knee extension. The physical examination will see the swelling and the guarding reaction or spasm that sometimes it masks the positive result of the test in the acute lesion. We have to test the Lashman anterior test and pivot shift test to evaluate the stability of the knees. Also, the meniscal injury, that a concomitant injury, and neurological and vascular state that should be evaluated every time. Imagine we send the standard knee film, including AP and lateral, or maybe sometimes oblique. Is the AP and lateral it is not complete. The CT scan and CT reconstruction or subtraction is beneficial for the treatment. Regarding to the MRI, we have no conclusion right now is it necessary or not. Some said that the meniscal tear and the osteocondral lesion can be seen in the MRI, not on the film, and it's also affected the decision regarding the surgery. In some old literature, they got the controversy in the Lowell and Winter, the pediatric textbook. They said that not to be done MRI as a routine screening tool because the high rate of the false positive reading of the meniscus tear and also high cost. But they said that it indicates in the patient with failed to improve the ROM, persistent effusion after conventional therapy, and the physical examination is difficult to interpret. But if the patient clinical evidence of the ACL torn alone, the MRI is not indicated. The more newer literature said that in kids and adolescents recommend to perform the MRI to ensure diagnosis, especially in the patient with the difficult clinical examination. And MRI is also the important tool to reconfirm the diagnosis for the parents, and to establish a clear and confidential environment for the treatment. The ACL avulsion fracture is classified by Meyers and McKeever in 1995. At first, they classified in only three class, T type, 1, 2, and 3, and then after that in 1970 by Dr. Sarisnik, they add on the 3A, 3B, and type 4. We're going to start with type 1. There is no or minimal displacement of the fracture. Type 2, there has a superior displacement of the anterior aspect, but the key point is an intact posterior hinge. The 3A and 3B is differentiate the size of the fracture. 3A is a complete displacement. Both of the 3 is complete displacement, but A is only ACL insertion. But 3B is a complete displacement of the entire intercondylar eminence. And type 4 is a comminuted fracture. Here's a picture of the Meyers and McKeever, modified Meyers and McKeever classifications. University of Pittsburgh also review and give the algorithm for the treatment of the tibial eminence fracture. If the patient comes to the clinic or the hospital with a traumatic knee effusion, they said that the AP and lateral film must be taken. And after that, we can divide into 4 types regarding to Meyers and McKeever. For Meyers McKeever type 1, now the treatment is the conservative treatment because there is no or minimal displacement of the fracture. We do the immobilization, both cast or sprint. The preferred position is now no consensus. Some said that full extension because there is no extension deficit. But some said the slight reflection will lower the ligament tension. The type 2 is controversial. After hematorosis aspiration, the close reduction with knee extension or hyperaciation must be done. But sometimes the meniscal interposition or insufficient congruency between the condyle and the avulsed tibial eminence can lead to the non-reduction. If it has a persistent displacement, the arthroscopic revision with fixation should be done. In type T and type 4, the worst result for non-operative treatment is confirmed. So the the arthroscopic reduction and internal fixation is a standard right now. The ORF is never. They said never recommend unless other lesion requiring open surgery is present. So, how good is the arthroscopic versus the open surgery? In Oxford review, they review about the arthroscopic treatment of the tibial eminence fracture, the systematic review of the different fixation method. They got the data from PubMed, Medline, Ovid, Google Scholar, and Embrace data. The area of agreement is the arthroscopic approach compared to the arthrotomy. Reduce the complications such as soft tissue lesion, post-operative pain, and length of the hospitalizations. Is that so good? This is a paper from KSSTA in 2006 in China. They used the standard transpatellar. That's going to be the open surgery. The standard transpatellar tendon approach and use the suture anchor to fix the ACL fragment. It's an avulsion fragment, sorry. The procedure is after the standard transpatellar tendon approach. They clear the interpost tissue, including posterior part of the transverse ligament, and they use the titanium alloy anchor. The result is good in the term of list home score and the Tagner activity score. You can see the improvement of the score after the open surgery. So it's not that bad, I think. And also in the AO Foundation, even you all know that AO has preferred the open surgery, but they still recommend the arthroscopic approach in their website. But for the open approach, they use the anterolateral approach of the knee. Open and use the clamp to reduce and then put the screw in or the suture pull out technique. So after reviewing up to these two papers, we can see that even the arthroscopic surgery is better, but the open surgery is good also. In the second round, we will compare between the fixation implant about screw, suture pull out, anchor, or the bottom systems. We have several fixation techniques from the screw, the lag screw, the suture pull out, the suture anchor, and other techniques such as the K wire or metal wire, the stable, the meniscus arrow, meniscus arrow, and the suture bottle system. The fixation recommendation from the JBJS 2001 and arthroscopy 1993, it said that it depends on the size and the degree of the comminution of the avulsed fragment. For the small avulsion, less than 10 millimeters, the multiple suture fixation must be done. But if these two combination, it may fail. In the medium fragment, 10 to 20 millimeter, the wire is less common, and larger than that, more than 20 millimeter, the cannulated screw is suggested. So I reviewed the biomechanical comparison between each technique. First, this paper published in Arthroscopy journal this year, 2018, is an arthroscopic fixation of tibial eminence fracture, biomechanical comparative study of screw, suture, and suture anchor. In the picture, they use a special techniques for the pull-out, for the pull-out, suture pull-out, and also use the suture anchor to fix the ACL part. But it's not so common, so let's focus with the group A and group B, that be a screw and the conventional suture techniques. So the start going to the group B. That means all the biomechanical tests regarding to the fixation, group B is better. So this paper, the suture is the winner. But if we searching more, this is the biomechanical comparison technique also. This paper conduct in Japan. They compare 4 types. This is the non-operative. Then intricate suture, retrograde suture, and the conventional suture pull-out technique. They use the translation, and this graph show that the intricate screw fixation has less translation than another group. So the winner of this is the screw fixation. So there's going to be some kind of the data like this. Some said that the suture is better, some said that the screw is better. So now there is no consensus about that. Another, this paper I attached to my presentation because there is some special like this. They use the endobutton to fix the ACL fragment and use the screw to post down there. But you know, it's not so common to use the fixation like this. In this paper, they compare between the high tension suture, fiber wire, outer bread, max bread, hi-fi, and auto-cord. All of that has the same result. No statistical significant difference. But if compared to the suture anchor, you see that there's some lower of the ultimate load compared to the suture group. But in the endobutton, it's more higher than the suture group, but it has some problem because there has some metal inside the joint. We also have a uncommon case of femoral-side ACL avulsion fracture. The possible cause could be related to the ACL insertional characteristic, the magnitude and the direction and rate of the force. Most of the case is secondary to the violent injury with forceful flexion of the knee and internal rotate or abduction of the lower leg. The workup could be missed in the AP and lateral, so the notch or tunnel view is suggested, or the MRI in the hematrosis patient. That's not so common to see the femoral insertion fracture like this. So, this is a picture from the KSSTA journal. They use the screw fixation for the ACL, for the femoral. This is a femoral fracture, femoral avulsion fracture of the ACL. So they put the screw in. So this is after the reduction and fixation. This is a paper from Thailand, from my friend, Dr. Niti. They report the case with the arthroscopic suture fixation in the femoral-side avulsion fracture. They use the suture anchor to put in the femoral footprint of the ACL, then loop around 2 times and then fix it down to the bone. For the point consideration in the pediatric age group, the patient and the parents' expectation must be talked. The pre-injury level of sport activity or the patient adaptation of activity and potential and the growth potential for the physeal plate. So we must concern about the growth plate injury. If they have the transphyseal bone formation, it will stop the growth of the bone, and it also can occur with the transphyseal bone block like bone parietal bone or quadriceps in ACL reconstructions. If the central zone is affected, it's called the LLD. But it affect everybody or not? Dr. Yu in JPO journal 2011, they used the MRI study to study the transphyseal ACL reconstruction in an adolescent with open physis. There is 5 of the 43 knees that has a focal physeal disruption without any clinical consequence. So my preference or how I did and what is my recommendation. My preference is the arthroscopic approach, and after that we do the copious, very copious lavage until the surgical field is clear, and prepare the fracture base, remove the hematoma and lateral meniscus. Sometimes that interpose inside the fracture site, and drill 2 tunnel, anteromedial and anterolateral to the anterior limb of the fracture with the use of ACL tibial guide, ACL jig, and 2 loop around ultra high molecular weight polyethylene suture counteraction the deforming force of the ACL, and 1 button on the anterior cortex. Sorry, I don't have the video because it's deleted when I sent the arthroscopic to maintenance. So this is a fracture of the ACL. First, we're gonna go inside first and clear this hematoma and also the anterior horn of lateral meniscus. Intraoperative, I used 2 suture to loop around like this with two tunnel, and on the anterior side, I used the button to tie it up and tie it together, all the 2 strings. When the intraoperative, we found it like this. It looked like the frontal chest equivalent in the shoulder surgery. So my recommendation is do the best way you can, either open or arthroscopic. If you want to do the arthroscopy, ask someone who can, and do your familiar fixation. By literature, is not much difference about the fixation method. And your choice always the effect post-operative care. The low strength fixation need more gradual rehabilitations, and follow up your case is the best way to learn. Thank you very much.